For the next session, B's knees, we are going to be talking about regional anesthesia for knee surgery. Over to Dr. Devesh Arora.
Good evening, ladies and gentlemen. It's 5:15 and I'm sure you must be tired. But I can assure you my lecture and the subsequent panel discussion which you are going to listen to will definitely keep you awake. I see only 50% of the audience left, but you will have a good time. So these are my set of disclosures for this lecture. I do not have any conflict of interest. It's just I'm an RA and a POCUS enthusiast. You will find a lot of QR codes. If you scan them, they will directly take you to the articles. And I'll stick to the allocated time of 15 minutes. This is how I have planned my lecture. We'll understand what is the knee innovation, what are the strategies which are available to us, any guidelines and final thoughts. So because of the paucity of time, I would basically focus on TKRs and a little bit on arthroscopies, although there are many surgeries which are happening in the knee region. So what is the analgesia regime for a knee surgery? The answer is multimodal analgesia with NSAIDs if not contraindicated, dexamethasones, paracetamols and a good nerve block, which we are going to focus on, and opioids as rescue. So how do we devise a RA strategy for knee surgery? First of all, for any kind of surgery, we need to understand the innovation of knee. What are the surgical steps for that particular kind of a surgery, and know the pain trajectory. This concept I'll introduce. What do you mean by pain trajectory? So what is actually the innovation of the knee capsule? Excellent study by John Tran and colleagues where they have showed the innervation of knee, and they have divided into 4 quadrants. For supromedial quadrant, from anterior to posterior, my dear friends, is nerve to vastus medialis, intermedius and supromedial genicular nerve. About the supralateral quadrant, there are 4 nerves from anterior to posterior. This is nerve to vastus lateralis, NVI, supralateral genicular nerve and branches from common peroneal. What about inframedial quadrant? It's from superior to inferior, the infrapatellar branch of saphenous nerve, the inframedial genicular nerve, and the infralateral quadrant is by infralateral genicular nerve and the recurrent fibular nerve. What about posterior knee innervation? It's again divided into 4 quadrants, and the principal nerve is the tibial nerve, which supplies all the quadrants. Whereas in superior medial quadrant, in certain patients, will have the contribution from the genicular branch of the posterior obturator nerve. And in some patients, we'll have some contributions from either common peroneal as well as sciatic. But the principal nerve is the tibial nerve, and whenever other nerves are present, they will form a plexiform plexus, which is named by popliteal plexus. So what are the surgical steps for TKR? This is the landmark article published very recently. Please scan this code and do read it. It's followed by a podcast also. Listen to that 40-minute podcast. All your doubts about adductor canal or femoral triangle block will definitely get cleared off. So what are the structures? If you look at TKR, the incision is 5 centimeters proximal to the patella and runs up till the anterior tibial tubercle or the tuberosity. And then the surgeons do a medial parapatellar orthotomy where they lift the structures like this, and the structures which are lifted are the medial retinacular complex, the synovial membranes, which are supplied by medial retinacular nerve, which is the terminal branch of the nerve to vastus medialis. Thereby meaning, if you look at the innervation of the medial capsule, which should be the most important to anesthesiologists for pain relief. What about the intra-articular dissection which they are going to perform? They are going to perform on menisci, ligaments, posterior joint capsule and some infrapatellar fat pad. This would be entirely taken care by the popliteal plexus, that is the supplying the posterior knee joint. So let me introduce you to the concept of pain trajectory. How many of us do actually follow the patient till the patient is discharged? Except for the surgeon, as anesthetists, are we following? A bilateral TKR would stay for 5 to 7 days. A unilateral TKR would stay for 3 to 5 days. The moment the catheters go off, do we pay a visit? I don't think so. So as anesthesiologists, it's our responsibility to know the pain trajectory. And you will ask me, Dr. Devesh, tell me what is pain trajectory? A pain trajectory is a graphical representation of the patient's pain intensity scores over a period of time. It involves the intensity of the pain in terms of NRS or VAS scores, the duration for which the pain is going to last, and how does it get resolved. So the surprising part is, in anesthesia literature, as far as pain trajectory is concerned, we do not have robust literature. This is an excellent editorial which not only covers the knee arthroplasty, but it covers all other shoulder, hips. So if you read this editorial, you would realize that the hip, काम नहीं करता यार. I would have got. Okay, so if you look at day 1, the pain scores hover between 6 to 8. Okay, even by day 6, they are hovering in the range of 4 to 5. So that means till the time patient is discharged, the pain scores are quite high. So we as anesthetists should think of not just 2-3 days, but of the 6 to 7 days till the time patient is, and maybe even afterwards. And if we do not treat the acute pain well, there are chances of patient developing chronic pain in 15 to 20% of knee cases. So what are the RA strategies which are available to us? Starting from neuraxials, plexus blocks, we are focusing more on the peripheral nerve blocks in terms of femoral, adductor canals, FTBs or IPACs, or there are various combo blocks like the femoral triangle or the adductor canal plus the IPAC. So what should be the goals for optimal RA strategy for knee surgery, my dear friends? It should be patient specific, okay? It has to be procedure specific, that is TKR we are talking about. It has to be motor sparing so that the patient can be mobilized as early as possible. And definitely we are in the era of opioid sparing analgesia for India, and in context of United States it's opioid free. So, and we have to provide optimal analgesia not during rest but during moments and during physiotherapy, so as to facilitate early rehabilitation. So how has the adductor canal block evolved over a period of time for knee analgesia? It was introduced first in 2009, and from 2009 to 2016, its importance for knee analgesia became more and more important. Initially it was said it was acting because of saphenous nerve block, then it was said it was blocking the nerve to vastus medialis, and till 2016, majority of the people were using the landmark-based ultrasound technology, by which it was meant that people were using a midpoint of anterior superior iliac spine and superior pole of the patella, which actually we know was lying in the femoral triangle. So papers published prior to 2016 actually stating adductor canal block were actually the distal femoral triangle blocks. So we are getting good effects. From 2016, 3 major landmark articles came into the literature, which I'll be showing you, and they have helped us in understanding the current concept of adductor canal block. So these are the 3 landmark articles which I request you to kindly go through them. Basis of this, they said if you use the anatomical landmark between ASIS and the superior pole of patella, midpoint, you will be in the distal femoral triangle. If you use the midpoint of inguinal crease till superior pole of patella, you would be in the adductor canal. That is the true adductor canal block. So another thing important, they said that sonographically this can be identified. The beginning of the adductor canal is where the medial border of the sartorius meets the medial border of adductor longus. And this, I call it as a horizontal namaste sign, which can be easily identified on sonographically. So they said if you wish to use the anatomical landmarks, use between inguinal crease and superior pole of patella. Number 2, sonographically confirm the beginning of adductor canal as the namaste sign, horizontal namaste sign. Number 3, they said the anatomical dissections as depicted in Gray's anatomy or Grant's atlas, they showed that nerve to vastus medialis actually lies in the true adductor canal. But that's not the case. The dissections which have been done by regional anesthesiologists in cadavers, they have shown consistently that nerve to vastus medialis, the moment it enters the true adductor canal, lies in its own separate sheath. So now you can understand, think over it. We were previously, prior to 2016, when we were doing a so-called adductor canal, we were in the distal femoral triangle, where the NVM and the SNS, saphenous nerve, lie very close to each other. This is how they look. They lie in the same compartment in the distal femoral triangle. Okay? And the moment we enter into the adductor canal, the nerve to vastus medialis is situated in a separate sheath, thereby making the importance that if you have to perform a adductor canal block, you have to make a conscious effort to identify nerve to vastus medialis in a separate sheath and identify the saphenous nerve and do a subsartorial plexus block also. So the next question comes. The adductor canal is roofed by vasoadductor membrane, which is very thin proximally, and it becomes more thicker and thicker distally, which has been shown by Wong et al., where you get a double contour appearance on the ultrasound. Next question comes to me, as all fascia have some perforations, is vasoadductor membrane impervious or it has got some perforations? If it has got some perforations, then I need not separately identify nerve to vastus medialis. Wherever I deposit, my drug is going to percolate in two compartments. There was a good news. In 2007, Tubbs article which showed that this membrane is perforated in 75% of the cases. Okay. Then came in 2017. This group showed that vasoadductor membrane is not at all perforated. Now this is the recent study in KJA where they have analyzed the 3D CT, the histological findings and immunofluorescence findings, where they have actually shown that the drug can seep across the plane. That is a good news for novices who cannot identify, but we have to have more RCTs to prove whether this is correct or not. So now coming to the next question, what are the volumes and the concentrations should we be using? This is an interesting study by Jaeger et al. 2015 BJ, where they showed that the ED95, this to fill the entire canal, which is around 8 to 11 centimeters in length, is 20 mLs. So if you wish to fill this canal completely, then 15 to 20 mLs is the volume which is required. And very recently published, they identified 3 volumes, MEV 90, 95 and 99. MEV 99 means 99% of the population it will suffice. This shows it's 18.9 mLs. So a 15 to 20 ml volume is good. And since we have to have a motor sparing, use 0.2% ropivacaine or 0.125% bupivacaine. Now we are in the era of evidence-based medicine. You will be questioning, Dr. Deveshwara, please give us the evidence. This is in the form of network meta-analysis, trial sequential analysis regarding which is the best block. Okay, they state that a proximal adductor canal plus IPAC or local infiltration analgesia is a good option. As regards IPAC versus LIA, if LIA is in place, that is a good local infiltration analgesia where we specifically target the posterior capsule, then IPAC is not required. If LIA is not in place, then IPAC is definitely to be given. Are there any guidelines to support what I am saying? I have given you good quality evidence. Now it has translated into the form of guidelines from the Prospect group. For those who do not know what is Prospect, Prospect is a conglomeration of surgeons and anesthesiologists where they sit together and evaluate the evidence in form of RCTs, meta-analysis, and give good possible recommendations. In 2022, they said adductor canal plus LIA is the option. But we need more evidence. This article has been already cited by Dr. Amjad, the ICAROS recommendations, where they state that preferably use a neuraxial anesthesia for hips and knee and use peripheral nerve blocks for providing analgesia. Now let me spark some controversy. I have concentrated more on the osteotomes and capsules. You'll be questioning, whenever we plan a strategy, we have to plan for incisional pain. So what about incisional pain? Do we need something else? So the area of the incision site is supplied by anterior femoral cutaneous nerves in its form of 2 branches, intermediate femoral cutaneous with medial and lateral, and the medial femoral cutaneous nerves anterior and posterior. Both of them are clubbed together as AFCN, which is a branch of the anterior division of the femoral nerve. If I am giving a femoral nerve block, these are certainly blocked. So what about if I am not giving a femoral, I am giving a distal FTB or a proximal adductor canal, which as the literature recommends you should be doing. So intermediate femoral cutaneous nerve, as you can see for yourself, it leaves quite early the femoral nerve in the iliopectineal fossa. This would not get caught whether you give a distal FTB or distal proximal ACB. But the FCN, the medial femoral cutaneous nerve, leaves the canal at the distal femoral triangle block level. So this group, Siska Bujan from Denmark, they are heavily propagating that we should block MFCN separately and IFCN separately. But to me, MFCN, if you give a proximal adductor canal block, because you are giving 15 to 20 mLs, the drug would move a little cranial also, and it would take care of MFCN. Let's look at the panel discussion, what other panelists feel. What about how do we tackle the posterior knee pain? Is posterior knee pain a reality? The answer is big yes. In contrast to posterior hip pain, which we were discussing, is little plus minus, but posterior knee pain is a reality. And it's supplied by popliteal plexus, which is composed, as I said, principally by tibial nerve, posterior division of obturator nerve, and whenever present, the branches from sciatic and the common peroneal nerve. So what are the options? We can do a selective tibial nerve block because tibial nerve occupies all the quadrant. We can do a good LIA. We can do a distal adductor canal block or adductor hiatus block because the adductor canal continues posteriorly with the popliteal plexus. Or IPAC, which was devised by Dr. Sanjay Sinha in 2012, and the SPANK block. The most popular option is either LIA by surgeon or IPAC by an anesthetist, but we have to remember that IPAC has to be done prior to the starting of the surgery. We cannot do IPAC once the surgery has been done. Now coming back again to my slide. I showed you so many nerves. You must be questioning me. You are providing me a solution that adductor canal or a distal femoral triangle is good, which will take care of nerve 2 vastus medialis and saphenous nerve and subsartorial plexus. What about other nerves? So my dear friends, in my opinion, I don't know whether surgeons would agree or not, the lateral capsule is not touched, okay? So what we have to focus on the medial capsule, that is the superior medial quadrant and the inferior medial quadrant. So the nerve, supromedial genicular nerves, originate from nerve 2 vastus medialis or tibial nerve. Now the literature is more or less convinced that it originates from nerve 2 vastus medialis. What is it? It's a branch of femoral nerve. It travels in adductor canal also. So if I am targeting nerve 2 vastus medialis in adductor canal, do I need a separate genicular block? That is my big question. There is a group which is heavily advocating that geniculars to be blocked. This has again stemmed from the chronic pain literature where the patients who had inoperable knee pain were being advocated for genicular nerves. What about the other geniculars? We have to concentrate on inframedial quadrant. Inframedial genicular nerve is derived from tibial nerve. So look at this interesting IPAC cadaveric study published in RAPM 2019 where they did proximal IPAC versus distal IPAC. Proximal 1 finger breadth above the patella, distal at the level of femoral condyles. And they give 10 ml of the dye. Look at these interesting results. In proximal injection, they showed that supralateral genicular nerve is blocked in 71% of the cases and in 100 of the distal. The most interesting finding is that the supromedial genicular nerve, which originates majority of the times from nerve 2 vastus medialis, if for a few minutes I believe that it's originating from tibial nerve, is also getting blocked. So I question you, do we actually need geniculars? And in this RAPM 2020 cadaveric study, they showed just 10 ml of the dye in proximal adductor canal was taking care of SMG, and that is a supromedial genicular nerve, which is a branch of nerve 2 vastus medialis. So again I question, do we need separate genicular nerve blocks? This is an aggressive group. Dr. Jeff Katzen from Duke University, they are heavily advocating that geniculars should be used. And they showed that there was around a good percentage reduction in opioids if you give geniculars in addition to adductor canals. So I'm almost coming to the tail end. What should be the RA cocktail for TKR? It has to be on continuous basis. You cannot do single shot things. You have to place a catheter, either distal femoral triangle. As a novice, you may not be able to recognize nerve 2 vastus medialis separately in the proximal adductor canal. So you do distal femoral triangle, that is not a problem. Or if it has become more and more expert, when you can recognize nerve 2 vastus medialis separately, you do a proximal adductor canal. LIA, if surgeon has done, you need not do a IPAC, and definitely it has to be a multimodal analgesia. What about my hospital experience? So this is how we have changed. Okay, currently we do try to identify nerve 2 vastus medialis. We do a modified adductor canal as I call. Previously I was not doing that. So, and we did a DNB thesis. We compared the quadriceps strength with a femoral nerve with a continuous adductor canal using a handheld dynamometer. It's around 1 lakh. And it was consistently shown that adductor canal is far better than the femoral in terms of quadriceps weakness, and it used to help us in early mobilization. So while I was preparing, I pulled out this video from my bank. This was from 2019. This is the way I used to do adductor canal, and I'm quite surprised that I might be impaling the nerve to vastus medialis. So I'm coming from lateral to medial, as you can see for yourself. My target is between 2 o'clock to 10 o'clock of the artery, essentially a periarterial injection, where cephalus nerve would definitely get. Amjad is raising his eyes. Most probably I have already gone through the nerve to vastus medialis. Do you agree or not? So nerve to vastus medialis is lying here somewhere. So my needle most probably has gone through that. Amjad, what do you say? So it could be here. After you inject, you could be saying it's here. So, but I am not intentionally blocking it. It was not getting blocked. So after reading the literature, so we have modified over a period of time. Now for the academic purpose, we use a nerve stimulator to identify the nerve to vastus medialis. Okay. So this is the block. Okay. So when we are close to nerve to vastus, this is nerve to vastus medialis, this is saphenous nerve, you get twitches, localized twitches, you can confirm. The moment you inject local anesthetic, these would disappear. So the nerve to vastus medialis, you can see for yourself, is lying in a separate compartment. As my needle will perforate a septum, it gives you a give way. And you would realize that two nerves are in separate. Now I am trying to move towards the saphenous nerve. And then after depositing on the side of saphenous nerve, we move towards the superior surface of the artery to block the subsartorial plexus. This is how our catheters are placed. We generally use a multi-hole catheters. You can see for the catheter is placed on top of the artery through those two compartments, taking care of those two compartments plus the subsartorial plexus. I am open to questions on this. Definitely we'll have a good discussion. That is why I told you my lecture is going to keep you awake. So please remember, one size does not fit all. It's good to have departmental protocols. Of late we have introduced the concept of intrathecal morphine 100 micrograms to increase the density and the quality of analgesia also. And we keep the patient's TKR in high dependency units for 2 to 3 days. And we use a PCA intravenous morphine pump as a rescue. What about ACLs? Okay. ACLs are very commonly done, and in 2019 there were SAMBA guidelines which showed that LIA was the best, femoral and adductor canals were not that good. Over the years there have been new literature where they have shown that adductor canal is quite a good block because it preserves quadriceps strength, so it should be preferred over the femoral for ACL. So what should be the take home message, my dear friends? She is my favorite actors. She said entertainment, entertainment, entertainment. I always say it's the anatomy, anatomy, anatomy. Always discuss with the surgeon the planned surgery, the duration, tourniquet use, and the physiotherapist their protocols. Know your skill. If I'm not skilled to perform an advanced level block, then I should not be doing it, and plan your block accordingly. So thank you very much for patient listening. Recently Dr. TVS Gopal had conducted AORA 2024, which was a successful event in Hyderabad, and you are all RA enthusiasts. I welcome you to AORA 2025 in Amritsar. You have already applauded for me. This was just a reminder that you have to. Thank you very much.
To continue with the panel discussion, may I request Dr. Debesh Bhoi to kindly moderate the session. For the panel, may we have Dr. Deep Arora on the dais, Dr. Abhisar, Dr. Anuj, and Dr. Pradeep.
Okay. First of all, thank you, Dr. Anshuman and Yatharthcon Hospital for inviting this panel discussion to moderate. So I think this is the panel that is going to discuss about the knee surgery. Okay, and we have a very good panel for discussion. Just to introduce the topic, as Dr. Devesh has already told that there is, I think, the enough evidence and everything is there to ye. So just we are going to focus on the practical aspect of how normally we do in our setup or normally in that case. So just to introduce the topic, and we have a very good Dr. Devesh, Dr. Deep is there, and Dr. from the surgeon side, Dr. Katiyar and Dr. Anuj. So obviously Dr. Devesh has already told about the different technique. So I want to just question out the Dr. Deep, sir. So what is your choice of combination of block for unilateral TKR? I think Devesh has already analyzed things. So is it the same or some we are going to differ?
So we started with a combination of in 2016 adductor canals. It used to be distal adductor canal and selective tibial nerve block.
Exactly. I don't think you are practicer.
But now over the years it has changed. We migrated from selective tibial nerve block to IPAC, and then the surgeons started feeling left out. They wanted to be empowered, feel that as if they are also doing something. So the posterior capsule infiltration is now done by surgeon on table before they fix the implant, and we put in a distal femoral triangle catheter.
Okay, so your choice is distal femoral triangle
catheter with LIA. LIA which is done by surgeons.
Okay, so you don't do IPAC.
Now that LIA is done in the posterior capsule, we don't do IPAC.
Exactly. So that means the whole LIA that is covering the anterior capsule, posterior capsule, all is done by surgeon, or you don't do anterior capsule, or the LIA that is done by the surgeon.
Yes.
It's a whole.
So this is mainly posterior capsule because we are taking care of the anterior part by. Yeah.
Okay.
Because remember our setup in most of the Indian setup it is bilateral.
Exactly.
So the volume also has to come in, because if you do 150 ml each side, it becomes a bit too much. So 40 ml posterior capsule both sides we are still within limits.
So one point just again, as you said regarding bilateral, that is in our Indian setup most of the thing that bilateral TKR is also some of the day. So do you think that still there is a role of epidural block, or still you think that it's always a peripheral nerve block? What is your take?
I have not done epidural for last 15 years, so I don't know.
Okay, Dr. Devesh, can you add on this? Because same thing, just to bilateral, because what is your...
I have a different opinion. Actually, it will depend on surgical facility which you are working with is like. So I have 2 full-time surgeons, 2 part-time surgeons. Full-time, one does bilateral TKR, wheel into wheel out is 4 hours. For another one is 5 hours. Visiting surgeon is 3 hours. So I have to cater to 4 surgeons, so I modify my practice accordingly. So because intra-op anesthesia has to be done, we definitely do CSE for those bilateral TKRs, and we put 100 micrograms intrathecally, 3.4 ml generally bupivacaine heavy is the standard dose, plus 0.1 ml, that is 100 microgram of morphine. Intraoperatively, we use dexmedetomidine infusions to keep them sedated for 4, 3, 5 hours, depending on the duration. And by the time they move to the recovery room, we do not give any top-up intraoperatively. Their limbs are almost fully. After 4.5 hours, they are able to move their limbs. Then we start the infusions. So there is a place in my practice for bilateral, definitely epidural.
Exactly.
Yes.
I think Dr. Gopal sir is also there. So can you add on sir one thing regarding the bilateral, specifically for the bilateral TKR?
Bilateral TKRs as a practice started in UK because there was too much strain on the NHS to do staged TKRs, patients coming in on 2 separate occasions for a knee. So to optimize their economy, they started doing bilateral TKRs. As a practice, bilateral TKRs at a single sitting is not something we do anymore. We typically do staged TKRs, wherein the patient comes back for the other knee 48 hours, 72 hours later. That has been our practice.
Okay. Thank you.
In my hospital, bilateral TKRs are very common. So there is one surgeon who is very fast. So in a single go, he take around 2.5 hours to complete finished both the knees. So spinal is enough for anesthesia purpose. In his cases, I usually give bilaterally adductor compartment block and posteriorly for posterior pain selective tibial block. Okay, to reduce the volume. But in for the other surgeon who takes around 4 hours, I usually place continuous spinal catheter and I usually run post-operative analgesia using 0.1% of the ropivacaine along with the 1 microgram per ml of the fentanyl for 2 days. And believe me, most of the patients are walking.
So you are putting intrathecal catheter that you use 0.1%.
Intrathecal catheters, yes.
So you don't, sir, that you give a single shot adductor canal block for that year and then subsequently infusion for that year?
No. For surgeon where I have to use the catheter for this anesthesia purpose as well.
Okay.
In those patients, I am continuing with the this catheter for the post-operative analgesia. Otherwise, when I am giving the single shot spinal, I will give bilateral adductor compartment block along with the selective tibial block.
Okay. So I think as you can see, there is multiple different practice. Obviously, the institute and the surgeon specific, obviously the all concerned. But till that, now we are just think that as the discussion is going on regarding the adductor canal block, the femoral triangle block, and the LIA. So just next, for the surgeon perspective, I want to ask you, how much you think that the catheter, as your sir has said, are you comfortable with that? Sometimes it has been seen that the hindrance from the surgeon side, that if you are putting a catheter in that surgical side, it might lead to or increase the chances of infection or might take more time or something. So do you think that is something like that?
See, that's always a fight with the anesthetist and the surgeon always fight with the time, because time factor is always a fight for every one of us. But what I really feel is, like, intraoperatively we are putting a catheter too close to my incision site. I am a little bit scared. I don't usually do that. But if you want to put it in adductor canal, I am okay with that. But not the lower femoral. Means if you are just going it too close, then it becomes difficult for me, because the incision site you may never know. See, if you are doing a TKR, it's a big operation. Small amount of damage or small amount of mistake can lead to heavy loss for the patient and as for the surgeon.
Exactly.
It's a nightmare. So I would still prefer to be away from the joint as much as possible. And epidural and all this stuff, as we put in an epidural, definitely the motor power is at a loss. So we are definitely having a loss of motor power when we are putting in epidural, because to mobilize a patient from the next day onwards, it becomes very difficult. So if you're putting in blocks, particularly like the adductor canal and all those, it does make some sense to us, because a mobilization is definitely a part for us.
Okay. So Dr. Anush, same thing you differ something?
We are always worried about the catheter being placed too close to our incision to decrease the risk of infection.
I think we have seen now this, because sometimes you are not able to do pre-op also. In the post-op also sometimes I think sometimes your time constraint. You are putting, I think after putting all the dressing also, you could able to see the adductor canal and scan it and proximally. So I don't think that in any circumstances you are going to infiltrate your field. So don't worry about that. Okay. So next is, we're just coming on that. As already I think Dr. Devesh has already told regarding genicular nerve bloods, are they really required? So again, I think what is the sir's perspective, Dr. Deep perspective, because I think Dr. Devesh has already told that. So I thought the question directly goes to that.
So this keeps cropping up now and again, but the recent RPM, I think this month's issue carries this article, which categorically rests this. It says that genicular nerve block, this study says that genicular nerve blocks are inferior to IPAC plus adductor canal combination as far as dynamic pain goes. So I mean, so that is our surgeons also, every surgeon wants early mobilization, functional recovery, ERAS protocol and all that. So it doesn't fit in with
Exactly.
Can I ask? See, genicular blocks, I have come across some surgeons, like patients who are not willing to go for a TKR. So they are taking genicular blocks as a usual. So in that case, how good are they? How good are they? If patient is not willing for an replacement, so if you're putting it in a patient who's not willing for replacement, how good are these blocks in those patients?
Okay, I can
And
add
how
on
does
that.
it work around? How much does it?
Exactly.
Yeah, that is what
Yes.
I'm putting it across.
Yeah, thank you very much for the question. Obviously, I'll add on. So I have seen many patients, usually, the moment they sometimes, those who don't want a surgery or replacement, they usually come for the chronic pain clinic so that is there in any sort of recovery or something. See, the problem is that because sometimes the patient need a surgery, but because the comorbid of the patient, exactly they might not, because of grade 3 or grade 4 knee osteoarthritis, nobody can spare him from that pain. But still, if there is, you have to respect the patient decision, exactly what he want. If he don't want a surgery and he still get rid of the pain, then obviously he can give something. So that in that case, geniculate nerves gives a good relief for that. Because we do what normally we do is that we first give a diagnostic geniculate nerve block. So normally, as Dr. Devesh has explained, the geniculate nerves are not only the 4, rarely around more than 10 or more than 9 to 10 nerves are there. So every nerve cannot be targeted. So specifically we target for the 3 major nerves, that the supromedial, supralateral and the inframedial. As you know exactly, the medial compartment is more and more involved. So the medial part should be, and subsequently the patient respond, that can go for the radiofrequency ablation at those 2 nerves. So there is, I think
So there are some patients, after this surgery, they complain of lateral calf pain. They usually complain of lateral calf pain after the LIA and ACB. In those patients, this infralateral genicular block might be helpful by using Gedison technique. When you are using this Gedison technique, it might be helpful in those patients who are complaining of the infralateral pain.
So anything, Dr. Devesh, you want to add? I think Shishir is telling something. So what exactly post-op lateral pain you are telling, Dr. Shishir?
Yeah, post-operative infralateral calf pain basically.
So the genicular nerve can be given post-operatively?
Yeah.
I have a question to surgeons. Are we anyway touching the lateral capsule?
No, we don't. We just slightly stretch it out.
Right.
Means that
So
we don't
can it
touch
cause that kind of a pain that we need to give?
I do not know the reason behind this pain. What may be the reason of this pain? I am not aware of it. Maybe because of the only retractors.
See,
maybe only because of retractor.
the Duke University, Jeff Katzen is aggressively promoting that you should block even nerve to vastus intermedius also.
Yeah.
Nerve to vastus lateral is also is promoting.
Sanjay Sinha he is also getting.
That is okay, but see, if they are not touching the capsule on the lateral side, why do we need to bother about those
Not
nerves?
only the incision which hurts, it's retractor, it also hurts.
Okay.
We just retract the lateral capsule.
and
We retract the
See,
capsule. Yeah.
it's retracted from a medial side to like this. Yes.
And we have taken it because we take care because it sometimes
It's not much
we
of a
take care
retraction.
of the patellar tendon also because if we retract it too much.
So that is my question. Is that retraction or whatever it is, it's that painful that we need to bother about the lateral components? I'm not sure.
Exactly. But obviously this is a very, I think there's a common thing that surgeon can it's a combined discussion between the anesthesiologist and surgeon that can help in that way.
Our surgeon can help in this way. Do these patients complain of infralateral pain in post-operative area?
Calf pain you say?
Yeah,
Calf pain?
calf pain, yeah.
Lateral calf
Yeah,
pain?
yeah.
Very rarely.
Exactly, medial is more.
Medial is the most common. That is the sure. Medial is the most common.
Lateral we
We
have
have
not
not encountered specific
any of those stuff.
lateral calf pain.
So anyway, okay, so I think let's again come back because this is.
Maybe we need more literature to solve this. Maybe another next 2-3 years we'll have more literature.
Even okay, so I think next thing. So do you really read catheter for unilateral TKR and single shot with dexmedetomidine? I think the first part is obviously we have already discussed, but this second part. So still, do you think that single shot with some adjuvant or something sort of thing that you can avoid a catheter? So as I think you quoted the few of the study that even the very good study from the Nasir Hussain and I think the Forensic Anesthesiology Network meta-analysis. So they found that continuous ACB, that arterial canal block with LIA or with IPAC, those are basically the combination that is the the evidence is still there. But nowadays if you post that, I think some of the literature are coming or the experiences are coming that single shot some people are not favoring, sometimes trying to avoid some use of adjuvant or something. So is there any sort of your take on that?
I think I would request everyone to go through that knee trajectory. It's not knee trajectory, it's for shoulder, hips and breast also. It's an excellent article. We tend to ignore the intensity of the pain and the duration. The moment the catheters are off, we think everything is normal, but it doesn't happen that way. So continuous has to be there. In America, they are promoting outpatient joint arthroplasty. By evenings, they discharge. I don't know how feasible it is in our setup and all. So I cannot say. It has to be continuous. That's what I feel. And if you wish to add adjuvants, we add dexamethasone 8 milligrams to the.
So you, okay, so 8 milligram you want to add dexamethasone?
I always add.
So it's only the adductor canal part, because there are so many local anesthetics that are getting used by the LIA, adductor canal, IPAC.
No, in only adductor canal. So LIA, though, it's posterior basically infiltration. So whatever the surgeon feels, they add sometimes ketorolac, whatever ADR,
okay,
they are comfortable. We do not
so
interfere in that.
I'll just add on one thing, doctor, because as you are telling regarding the pain trajectory. So if you see that graph that normally you showed, see the pain is not only the 1, 2 or 3 days. It's along the 4th and 5th and 6th day. So do you think the 4th and 6th, what can be the option in that way? Because if you think that part, how can you taken care of? Or
so our surgeons are very fond of using buprogesic patches.
I'll come to that.
They use more than what I recommend. I keep telling, see, these are meant for more for chronic, but they are very happy. It's a 7-day patch, number 1. 5 microgram per hour is a minuscule dose. Okay, it doesn't lead to nausea, vomiting or ileus kind of a thing. So our patients are very happy. They do not get night calls. So they say it's better on day 1 or day 2. Generally, without our knowledge, day 2 they'll definitely get it applied, and it gives them a 7-day window. So ultimately, it's the patients like smile on their face. Surgeons are smiling. I am also smiling. So I have no issues if they use. Ultimately, we have to give good analgesia for a good functional outcome.
So I think then I get back to Dr. Pradeep then.
Series of TKR, so his opinion should be.
So we tend to identify a subset of patients who are more likely to require this kind of a patch. Patients with a history of anxiety who are on antidepressants, already using some kind of pregabalins and stuff for chronic pain. So we find that these patients definitely will not be satisfied with just a combination of adductor catheter and LIA and multimodal. So we have gained this experience over years that these patients will require something more. So we identify these patients, and maybe second day, third day, definitely second, third day, we put them on this patch with which they go home and they're happy, but not as a routine.
Okay. So as you uttered regarding pregabalin, I just add on the one question. So do you think that there is a role of pregabalin, because initially literature there? Then
we use that, yes. Pregabalin.
So in which case, just to for the
as part of multimodal thing?
In which case, or specifically in all cases, you do give preoperative pregabalin? On
yes,
how much?
Yes.
In all cases, you
all cases. Paracetamol, NSAIDs, if kidney functions allow, if the patient is not 80 plus, and pregabalin similarly depending on patient's age and frailty.
And how much you give it?
So anywhere from 25 to 75.
75.
HS, yeah.
Okay. So I think I'll just straight come to Dr. Pradeep, because while we are talking about the pain and everything,
yes,
so I think your roles mostly, once everybody has most of everything done,
yes,
so
sir.
now your tough job is yours.
Yes, sir.
So how you feel that patient sometimes must say which anesthetist is better in your way, that he is good for you. So what is your take on the post-op part? So
post bilateral TKR rehabilitation is very challenging, sir. So we on the day 1 we get up the patient and make them stand only. So the very next day we make.
So the bilateral TKR.
Bilateral TKR.
That's day 1. There is no walk.
No walk. Only sit to stand with the support of walker, sir. And the day 2nd we make them mobilize, sir. Okay. And if we talk about unilateral TKR, sir, so from the day 1 we start walking.
So the second thing I'll ask you is that, because as you are using analgesia technique, do you find any difference of any specific analgesia technique has been used, or the patient has not got the adductor canal block or some sort of in the perioperative in the post-op during rehabilitation? Do you find any difference, or that patient is your job might be a bit of difficult or in that way.
Yeah, as we are seeing patient nowadays, sir, so I think Dr. Anshuman, sir, implementing adductor canal catheter, and as sir said in his presentation also, so there is a very less chances of quadriceps weakness. So it's easy for us to make them walk.
Okay, so I think that's a big round of applause for Dr. Anshuman, so that your patient must be happy on that. So I think again I'll come to that motor sparing, as I think Dr. Prabhu's daughter. So do we really, that if the patient is not walking the first day, you're not mobilizing the patient the first day, still we need a motor sparing anesthesia technique, or you can go to increase the concentration?
No, see, we are at any point of time, you are not going to mobilize the patient on day one. So even if you want to see the effect of spinal with additives, definitely stays for a long time. Putting in epidural is unnecessary. Means if you put in an epidural, you cannot just remove it after the second day. Then what is the point of putting in an epidural? So it's better that even if I don't mobilize, the patient is pain-free. So why do I need to worry about it? So it is not only that mobilization has to be the mainstream of putting in an epidural or not putting in an epidural. See, there are patients who don't want even a slightest bit of pain. They will say, Doctor साहब दर्द बिल्कुल नहीं होना चाहिए ऑपरेशन के बाद, चाहे कुछ हो या ना हो, उनको जरूर epidural डलवाते हैं, because those are the subset of patients. Even if a small amount of pain, they will complain. So those bilateral, you cannot put in both the adductor canals and have those effect. So it's better to have an epidural in such cases, and even though milder doses will definitely help us to achieve the same results that we want at any point of time.
So I think
one challenge all orthopedic surgeons we have faced and we are still facing is the patients are suffering from arthritis, and the only thing they are concerned and they're afraid of is the post-operative pain after TKR.
Exactly.
So where this is no, it's not an appearance. We actually have to work together,
obviously,
to actually counteract this and help the patients, come over this fear. If we have to achieve better and better in this area only, because that is the only question they ask. They are ready for the surgery. The only fear they have is the post-op pain, because anyone who goes after surgery and they meet their relatives and friends, they have their own horror stories to tell others, and that is what makes the other patients feel very, very wary of, consenting for a surgery. So post-op pain may, and like you said, Dr. Anshuman has been giving those blocks after surgery. So now we have good night's sleep after surgery. We don't get any calls now.
Can I add something?
Yes, sir.
I strongly feel that we have to set realistic expectations from pre-operative period of all patients. They should not be under the illusion that there will be zero pain.
Exactly, that's very
That is very important. Secondly, when we talk about epidurals, why we moved away from epidurals, again a very strong thing, and personal experience with a close friend who underwent a bilateral TKR under epidural, male patient, landed up with a urinary catheter, and then UTI, went into septicemia. So these are the free gifts we distribute to our patients, and when we do away with epidurals, our catheterization rate has come down to less than 5%. We don't routinely catheterize patients.
Actually, that's I would have asked same question also, because most of the time in the scene in the THR or some TKR patient, sometimes you think that patient is getting the long surgery. We insist on the sometimes surgeon do a catheter sometimes or like that. I think that the reason might be sometimes you can avoid catheter if the time limitation is less, obviously. So I think we have covered up those things. So again, for the surgeon, I think as per the technique of as you can see the nerve to vastus medialis and those technique of muscle splitting or separating, what is your take on that, which is the typical planning of the surgery and all, so that can be avoided or something that...
See, you cannot just go about doing anything, but it's just the subvastus approach that we always use. So in at all, we are not damaging the nerves at all, we are just trying to save as much as possible in those stuff. So if you have a meticulous subvastus approach, I don't think so that's much of a pain is just taken care of without anything else.
Okay.
You know the proteins, parapatellar or subvastus, midvastus, disturbed. But definitely the patellar tracking and the post-operative pain are much less in subvastus and midvastus as compared to the parapatellar.
And I think regarding that ligament or something, the tissue cutting to conserving, I think that the approach has been come from surgical approach. I think that has
The
been
more ligaments we release, the more will be the pain.
exactly. And more, the less ligament cutting or like that, I think that is going to less pain or like that.
That's the main role of robotics that's come in. The robot, what does it, what I have seen last 1 year between the conventional and the robotic is that the robotic is more kinematic alignment. It cuts the tibia in more varus, the more tibia is being cut from the medial side, so there is lesser of release and patient are pain free. They are much happier in the
Exactly.
and as well as 3 weeks. But the conventional TKR, they are more aligned perfectly, they are more painful. We don't know the long term what is happening, but the early outcome what we see, the robotic knees are being cut in more varus.
Okay. And is there any change of your
They
side?
are cutting more varus. That is actually a purview and domain of orthopedic surgeons, the alignment of knee post TKR. So we earlier with the conventional TKRs, we were trying to achieve a different, the previous alignment, but now it is kinematic alignment. There, the post-op pain and rehab is better, which we do with robotic.
Exactly.
But the long-term results are yet to be seen, and that is because the patient during the disease course develops an axis of contraction of various muscles. If we realign it to, let's say, his 20-year age group alignment, we disturb the axis of contraction, and that is what gives him more pain. So he will need maybe 6 months, 8 months or 1 year to realign his muscular axis and contractions. So that way robotic surgery has been giving less pain. Yeah. But then outcome 10-20 years. We don't know. We are still studying.
Exactly. Now,
Debatable.
I think robotic workshops are also going on in that way. So, I'll just add on one point to Dr. Devesh and Deep sir regarding the revision TKR. Suppose that patient is next revision TKR. So, what will be the mode of analgesia or something different or the same thing that you practice?
I deal with very less of revisions, so I practice the same protocol as I would do for a primary. I think he's the best person to answer this. He deals with a lot of revisions also.
Revisions requiring both long stems, both sides, longer incisions.
Exactly.
So there are regular protocol fails. So there I go for ESPs. Sometimes we do take grafts also from iliac crest, and it is so remember from T12 to about S1, S2 you have to cover.
Yeah.
And one ESP at L3 with intermittent bolus of 15 ml every 4 hours.
So you put ESP catheter for this?
Yes.
Okay. So anything, so Dr. Amjad, TVS, or any take on revision TKR analgesia technique at the same? So still there is. So Anshuman, please stop me whenever it is, I think.
Revisions that focus. And then what about post-op pain? Epidural fusion. Because there's one more center here. I moved from Fortis to here. And a lot of
Anytime you can finish. Just to.
20-30 revisions every month, and all extensive ones. Dr. Atul Mishra does. So that is why it's come from Fortis. So I asked him, what do they do?
Okay, I think that is again obviously that many things, many practice. Obviously, if you see the TKR, there are analgesia technique. Obviously, you will find so many things in that. So I think already you have covered up this the daycare procedure. Again, we are not going to cover up this. Unilateral TKR, do you really have to worry with the motor block? I think that is also we have covered up. Only I think one I think that is suppose in some cases you are EKR or unicondylar, that is. So in that case, what is your or how the tissue or the incision site or the tissue damage, how much it is?
It is much less. In unicondylar knee replacement, the incision is smaller, the patellar retraction is less, the cutting is less, everything is less. The pain magnitude is much lesser as compared to the complete total replacement.
So sir, Deep sir, again, I'll add your yes.
So a single shot adductor canal with LIA.
So I think the practice is same for the, even it is a,
He says
Single shot.
okay, single shot, okay, yeah. So if it is a unicondylar, less pain, do you go for a single shot? If it is a adjuvant, what adjuvant you prefer, sir?
So we usually give IV dexamethasone, we add clonidine there.
So the dual adjuvant. I think recently there is some also paper is coming on the dual adjuvant. I think mixing of dexamethasone, dexmedetomidine, and they just, I think more and more paper will come up in that. So I'll just go to Dr. Pradeep again. So what is your role whenever a patient has undergone suppose this type of cases, because
Yes, sir.
the challenge is same for you.
No, handling such patients is easy, sir.
Easy. So obviously that's good then. I think. Okay, I think thank you very much. Actually, we had a very good discussion, most of the practical aspect. So anything, I think I can, Dr. Anshuman? You can.
Thank you, everybody. Thank you to our panelists also for a very exhaustive discussion. May I request Dr. Amjad to kindly help us to felicitate our guests. Thanks to Dr. Debesh Bhoi for moderating this session. Debesh sir, this is for you. Thank you for being here. And thanks Dr. Abhisar. Dr. Abhisar? Thank you, Dr. Amjad. Now I hand over the mic.
Thank you. I sincerely thank all the faculties, both who were part of the live demonstrations and also the master class. It's not easy to speak continuously from morning 9 till now. It's already 6. And then discussing with the same enthusiasm as we started in the very beginning. And a number of times we got this term that Dr. Anshuman has done this, Dr. Anshuman has done this, and even Dr. Manish was kind enough to say this, not Yatharthcon but Anshuman-con, something like that I heard. So thank you, but Anshuman is just not a face. I mean, we have the whole department with me, and it is not possible for a single person to perform everything. It's not possible humanly. So I have a team, so I would like to ask, I have Nivedita with me. I have Shipra. Shipra, can you just please stand up? Shipra. We have Maninder with us. Maninder is in the back. We have Prerna. We have Anvesha. Anvesha has joined as the chronic fellow person. And Ritu there. And a few cases are going on behind also, so people are down below. So thank you. So for all this team, it's not possible for one person. And I thank you all. I suppose that the concept was that if you think, I knowingly kept the talks as 15 minutes. And Amjad said me, you want me to speak about shoulder in 15 minutes? I said, can you talk whatever you want in 15 minutes? The panel discussion will take care of everything, rest of the things. And I believe the discussion that we had with the surgeons and the physiotherapists, that will also stimulate your brain why the surgeons are grieving or why they are shouting, what they want from us and what the physiotherapists want from us. See, giving a good block is very nice. If the block is dense, they have fantastic pain relief, but is it really necessary? That we need to see and find out. So as this is done, we are